Good afternoon, one and all. Before we start today's webinar, there are some housekeeping rules I would like to announce. Kindly mute your audio and also you would preferably switch off your video to improve the bandwidth. You can submit your queries and doubts regarding the discussed at the you're requested to fill them and it will be in the chat box of the Zoom platform. It's my pleasure to introduce Dr. Anant Band to you all. He is the adjunct professor in Center for Ethics, Yenapoya deemed to be University. He has worked extensively in global health, bioethics, and mental health for the past 18 years. He was the president at International Association of Bioethics and was also in the advisory board of the RATIONS trial. He was also a trainer for the RATIONS field trial team. I now invite Dr. Anand Bhan to give his introductory remarks.
Thank you so much, Pavitra. Welcome everyone to the webinar. This is a very interesting webinar because it's going to be speaking to some very innovative research which has happened over the last few years. I would like to mention that we have participants from across India representing clinical medicine, public health, academia, civil society, as well as the service sectors. We have also received registrations from many countries, including from Senegal, Myanmar, Uganda, Middle East, Sweden, and Australia. I see well over 100 people have already joined, and I think over the next few minutes, there'll be likely more people joining. So as many of you would know, the RATIONS trial was conducted in the state of Jharkhand in India between 2019 and 2022 and received global attention after the results were published simultaneously in the Lancet and the Lancet Global Health journals earlier this year. Today's webinar specifically will be running from 2:30 to 4 p.m. India time, and we will try and keep to time. The speakers for today are going to be co-PIs from the study, Anurag Bhargav, who is a professor in general medicine in Yenapoya for the last 8 years, also heads the Center for Nutrition Studies, and Dr. Madhvi Bhargav, who is associate professor in the Department of Community Medicine at Yenapoya. And both of them led the study with colleagues in ICMR and working closely with the National Health Mission Jharkhand and with a very large and dedicated team. Both Anurag and Madhvi have worked for well over 10 years as founding members of Jan Swasthya Sahyog, which is a well-known not-for-profit organization in Chhattisgarh, and have extensive experience in clinical medicine and public health across all levels of care. I would now request Anurag to kindly introduce the Honorable Vice Chancellor, who will give his welcome remarks and introductory remarks on behalf of the university.
Good afternoon, everybody. It's my pleasure and privilege to introduce Dr. M. Vijay Kumar, our Honorable Vice Chancellor of the university, who is a professor also of surgical oncology and Professor Emeritus of the Rajiv Gandhi University of Health Sciences. Before his tenure at Yenapoya, he was director of the Kidway Memorial Institute in Bangalore, which is recognized as a state cancer institute. Dr. Vijay Kumar is a fellow of the Royal College of Surgeons, the American College of Surgeons, and has been invited faculty by various institutions in UK, Germany, France, and has delivered various prestigious orations. At the university, he has been instrumental in setting up the Zulekha Yenapoya Institute of Oncology, the MCH program in surgical oncology, a DM program in oncopathology, and he's involved in initiatives for increasing community awareness and screening for cancer in the district and beyond. The Center for Nutrition Studies was also established during his tenure, and we have received his consistent support for our activities. Over to you, Dr. Sir.
Good afternoon, everybody. At the outset, I should thank the organizers and the moderators for inviting me to be a part of it. And I also welcome, on behalf of the university, all the participants from India and outside. I already see it has crossed more than 120. And the initiative has to be applauded for obvious reasons. But from my side, and from my side, who's opening? Who's opening? May, because not my talk is only introduction, that's okay. But when serious talk is going on, it will be disturbing others. I'll request once again that kindly mute yours. Thank you. See, having said that, I go back on my memory lane about tuberculosis in our state where I come from, Madras team. There was a chemotherapy center they used to call in Chetpat, Chennai, which has done a lot of clinical trials about domiciliary care in tuberculosis. That is how I got introduced to tuberculosis at that point of time as a young MBBS final year student. We were also taken to the sanatorium, it's called as Tambaram TB sanatorium those days, wherein we saw people suffering from tuberculosis being isolated out from their homes, and they are kept separately, hoping that they will get cured by only nutritious food. That time, the nutritious food was milk, bread, banana, and egg. This was the scenario I'm talking 48 years ago. Coming to the tuberculosis part in our country, whether this sort of trials or clinical research is useful at all, if I ask myself, the answer should be, it should be useful for the society at large. How will I measure it, whether it will be useful? I just went through the TB burden in India. It is alarming, actually. It is much more than my specialty, that is cancer, where they are telling that it is more than 3 million are affected, and it is highest in the world. And mortality is also reaching around 50,000, and that too in the most productive age. And the highest number of multi-drug resistant tuberculosis also in our country, making a case that how not only prevent or treat people, but also prevent it. And if simple measures can prevent it, nothing like that. And that is what this whole study is all about, which they will be detailing later. And what are the controls? Because the people are coming from not only from India, but outside India, I was told. So for the benefit of them, what is happening in India as far as the control efforts, if you ask me, they are very ambitious to bring it down by 2030 by 80%. And also the reduction rate by 90% in 2025. That is the projected figures. And we have moved from the conventional methods to the molecular diagnostics for like PCR. Thanks to COVID, I would say a lot of machines of PCR have come into existence because of the COVID. But on the other hand, it is the same COVID which took away the initiatives started for tuberculosis and even treatment. They could not reach the places. They were not allowed to go out of the districts. They could not reach the facility to get the treatment. That was a setback by the COVID. But on the other hand, COVID helped us to improve the laboratory services. And the same setback was there for cancer. When HIV came into the existence, you all know, for a decade, there was no money for oncology was allotted because it was all diverted towards HIV. The same thing happened during COVID. Everything was diverted toward COVID. Having said about India, one more thing about Indian subcontinent about tuberculosis is the government of India, through the state governments, etc., have initiated the programs where there are several centers at the district level and the city levels were created where anti-tuberculosis treatment was given free of cost. and they have to only approach, and it was given free. That was the first initiative, I would say, from the government, where to eliminate by treating them. Now, today's webinar will be about the results of the ration study, how to prevent them, that they will detail. Coming to our own university, that we organized a national workshop for the development of the policy document in nutritional care and support of TB in 2016. And this later led to the Nikshay Poshan Yojana and Nikshay Mitra scheme. These are all, Poshana means it is nutrition actually. And coming to the last part of it, which will be detailed in today, would be the NFA-led multi-institutional trial, the RATIONS, which address the twin challenges of high TB incidence and TB mortality. And happy to see that despite challenges, we have actionable findings. And I once again welcome every participant for this program. And once again, thank Dr. Anurag Bhargav and Madhavi Bhargav to invite me to be a part of it. And I only hope that everyone participating today will be not only enlightened, but it will be a practical solutions which can be doable at your level. Thank you very much. Jai Hind.
Thank you, sir, for your kind words. And just to add that sir has been a co-traveler in the RATIONS trial, and his support during many turbulent times of 3 years of RATIONS trial have been very, very invaluable, without which we would not have been able to do it. So with this, I will start sharing my slide, Pavitra.
Okay.
So RATIONS is an acronym of reducing. Well, put this away. Just a moment, I want to put this away. Where does this go?
No, that goes by its own.
Okay, it goes on its own. Okay. So reducing activation of tuberculosis by improvement of nutritional status, a beautiful acronym, very apt for this trial. It was kindly supported by India TB Research Consortium, ICMR, New Delhi, and Yenapoya, along with National Institute of Research in Tuberculosis, Chennai, and State TB Cell, Jharkhand, led this trial. So this is our team when we started in August. There was an intense training program for 5 days where Dr. Anant was also part of the training. And we had training about nutrition assessment, counseling, various other measurements, various ethical aspects, GCP certification. And we also had 3 TB champions within the team. And that was the beautiful start. So before I start with the trial itself, a little bit of a background on why this trial. And throughout this trial, before this trial, and even now, there are 2 groups of people who discuss why do we need a trial. There is one group which says, why do we need this trial and prove something so obvious? And to be honest, I belong to this group for some time in the beginning. And then there was another group which said that there is no evidence towards importance of tuberculosis, undernutrition and tuberculosis for prevention and care. So this is an X-ray of a participant of our trial, just a 14-year-old girl with extensive lung disease, as you can see in the X-ray. And this was a recurrent TB at the age of 14 years, a household contact of a patient with tuberculosis. So at 14 years, this was a recurrent case. So there are a large section of society which is living in a tuberculogenic environment where there is high exposure to infection because of higher prevalence of tuberculosis disease, some of them having very advanced disease, compounded by overcrowding, poor ventilation. These are also the people who then become vulnerable to development of disease. So if it is 10% risk of development of disease, lifetime risk of development of disease in you and me, these are the people who have higher chances of developing disease because of various vulnerabilities and risk factors, with undernutrition, most important out of it, along with alcohol, smoking, HIV, socioeconomic distress, which are all interrelated. Once they develop a disease, there is a delay in reaching the diagnostic facility. We know in various studies of caskets of care, attention and care, linkage to treatment, their ability to adhere to treatment, a lot of out-of-pocket expenditure, medical poverty, the stigma, ability to get back to work. So at the end of the treatment, a person should be able to work. So that should be the aim of a good management and care. Coming to undernutrition, apart from, we all know about the various risk factors, but globally, undernutrition plays an important role as well, where 19% are attributable to it. In India, according to our reanalysis, almost 35 to 45% of TB cases are attributable to undernutrition. And we all know that in UK, even before the chemotherapy came in, we were able to see decline in TB mortality because of improved living conditions. So WHO defines, irrespective of presence of tuberculosis, WHO defines areas where, depending on the prevalence of undernutrition, we can stratify the region according to, having a critical situation or a serious situation, poor situation, etc. So till the NFHS 4 survey, we were in a serious situation where we had high levels of undernutrition. In NFHS 5, there has been a reduction where we have reached a so-called poor situation where we have medium prevalence. But when we stratify by wealth index and various castes and in scheduled castes and tribes, we see that there are huge proportions and the situation is serious. So India has a twin burden. On one hand, we have a large reservoir of people with TB infection, almost 300 million as per the National Prevalence Survey. And then there is a large pool of people with undernutrition who then have this risk factor and develop a disease. So to summarize, and we keep hearing this, that TB and undernutrition are bidirectional. That is the opening line in many of these research studies, but we call it a vicious cycle, where somebody who has undernutrition, it acts as a risk factor, has a disease, undernutrition becomes a comorbidity for them, the disease worsens. They can affect the drug absorption. It can cause drug toxicity, and there are poor treatment outcomes. Even after treatment, there's a possibility of relapse. So this is not just the case of Jharkhand where we worked or Chhattisgarh where we worked in past. The National TB Elimination Program data of 2018 also indicates similar problem at national level. So with some groundwork on observational studies and various advocacy work that we did in past, we finally embarked on this trial in Jharkhand, which is, and we are based in Mangalore. It was done in 4 districts, Ranchi, Saraikela, Kharsawa, East Singhbhum, West Singhbhum, and we chose 28 tuberculosis units. There are various reasons why we chose those 28 tuberculosis units. You can actually see the links Pavitra will share of the articles for detailed methodology. But we started, after a preparatory phase of 3 months, we started the enrollment on 16th August. This overlapped with the COVID time, so our enrollment got delayed, and we completed the enrollment in January 2021 and completed the trial in August 2022. So Jharkhand is a very beautiful state, land of trees. It has 24 districts, a lot of natural resources, predominantly rural, high scheduled tribe population but high levels of undernutrition as well as poverty. The case notification rates are high, almost 130 per 100,000 population when we started at that time. But apart from this beauty, there are also problems, and that is there are difficulty in access, they're difficult to reach areas, there are problems with livelihood, a lot of people dependent on forest produce and daily wages. So coming to the trial methodology, I'll take a moment here that two papers that are published are basically have two sets of populations. The 2,800 patients who were diagnosed with microbiologically confirmed tuberculosis, diagnosed in National TB Elimination Program, Jharkhand. So as and when they get diagnosed, we enroll them in the trial. And the second set of population is the household contacts of these patients, 10,345. So in the intervention arm, in the control arm, where we were expecting more incident cases, there was a slight imbalance. We had less number of household contacts in the control arm, and intervention arm almost 900 more, 5,621. So the primary objective with the hypothesis that the nutrition improves, reduces TB incidence was to see the difference in incident cases in household contacts in both the arms over 24 months of follow-up. The secondary objectives, mostly in the patient group, that is to look at TB mortality, the change in weight, improvement in BMI, improvement in functional status. I'll come to functional status in a bit. Loss to follow-up, and severe adverse effects to TB. There were multiple sub-studies which I will not touch upon today. So as I said earlier, patients in both the arms received the intervention irrespective of the arm of the trial, and family members received the intervention, extra food support during the treatment period of the patient in the intervention arm. So it can be called like an 1,100 ton study because we distributed 1,100 tons of food during that period. But more importantly, the cost of the basket. So I'll be quoting 2019 costs. Patient basket cost around 1,100 rupees per month, which included the micronutrient pill, the delivery charges, and the delivery charges. And the adult contact basket cost around 325 rupees per month. So the children below 10 years of age, they received half of this basket. We had created 4 sub-depots, and there were registers that were maintained. It was a very challenging task to deliver, and I must congratulate and compliment our field staff who braved many, many difficult circumstances to make sure that the food is supplied doorstep. Some of the urban families, they decided to pick up the food, but most of the patients wanted to be delivered the food at doorstep. So enrollment, as I mentioned, it got delayed, and we completed in January 2021. At the baseline, we looked at demography, anthropometry, symptom screening because we wanted to identify the co-prevalent cases who were having tuberculosis at the time when the index case was diagnosed. And then we checked for pedal edema, blood pressure, oxygen saturation, and Eastern Cooperative Oncology Group score, which I will come in a bit, in all the patients. We triaged the patients to identify sick patients so that to prevent deaths. So anybody with BMI, any patient with BMI less than 14 or less than 16 with pedal edema, with hypotension, low oxygen saturation less than 94, not able to move, having severe anemia, all these patients, we facilitated their admission and management. And we followed up all the 2,800 households for 2 years. So it was a monthly follow-up for first 1 year and then quarterly thereafter. Eastern Cooperative Oncology Group categories have been used in cancer care very often. We use this, it's a very simple marker of ability of a person to do normal work. So you and I fall in category 0, and progressive numbers indicate deterioration, where 4 is not able to do any self-care and confined to bed or chair. So a question comes whenever it's a food delivery trial, how did we ensure delivery and consumption? So definitely we did not do any directly observed therapy as far as this intervention is concerned. Food insecure community, that was the best marker that we could think of, but we had a lot of processes in place to make sure that the food that is delivered is used appropriately. So we had a network of 4 sub-depots. We maintained stock registered. Every time food was delivered, field workers shared geolocations and the recipients would countersign. Similarly, at household level, we had a lot of reinforcement. We could check the milk packets, at least, whether they've been consumed or not. And the phone numbers in the participant information sheet really worked very well. Whenever there was a delay because of COVID, we used to get calls as investigators about the delay. And of course, there is a lot of triangulation that goes at a community level. So when we look at on a large scale, it may look very daunting, but at the community level, there is a lot of local monitoring that goes on with the help of Sahiyas, the village leaders, and the feedback from the program staff whenever there was an issue. So the triaging worked very well. These are some of the pictures where somebody was completely bedridden, a 52-year-old person, and this was the reporting by our field staff, which is as good as our postgraduates in medicine sometimes, where there is age, there is weight, height, he has calculated the BMI, and he has indicated the saturation and low hemoglobin of 4.2 and his ECOG score. This patient fortunately was referred and he was saved. Next slide. So these are some beautiful pictures from the slide. We had a lot of sub-studies also where we looked at body composition, hand grip strength. We checked for micronutrients as well. Next slide, please. And in a trial, it is important who ascertain the primary outcome. So the screening, of course, was done by our field workers who were also delivering the food. So, but the patients, when they were identified, contacts, when they were identified as having any, what is that marker? Identified any symptoms, they were referred for sputum examination, for X-rays depending on the availability in the facility, either in a public facility or in a private facility. And so the medical officers finally diagnosed the incident case, and they were aware of the RATIONS trial, of course, but they were not aware of the arm. Next slide, please. The trial coincided with the COVID times. So you can see in this slide how the enrollment proceeded. So the first wave, there was a hard lockdown. As investigators, we were not able to travel for 2 or 3 months. But once it was open, we could travel. But there was a lot of disruption in TB services. There was disruption in travel and transport. So the delivery of food became challenging, but we could definitely manage it. Because the respiratory nature of the disease, we required a lot of training and morale boosting of our field staff. Many of us ourselves and our family members suffered at that time. And we managed early vaccination of our staff during that time. So I'll talk about the baseline characteristics and give the slides to Anurag. So at baseline, as you can see, the risk factors, most importantly. So MDR, very less, 3%, HIV, 0.3%. But you can see that the history of tuberculosis in family members was very high. Tobacco use, yes, high, 5%. But if you look at the undernutrition part, more close to 50% were severely underweight with a lot of, yes, this is definitely patients. So more than 50% were underweight. Hypotension was present in a great number. Anemia was present in 88%, and out of these, 7.5% had severe anemia. And if you look at the ECOG that I described earlier, only 3% were able to walk normally, and we had high tribal share of the population. If you look at the contacts, next slide, the families were beneficiaries of public distribution system. Tobacco and alcohol consumption was reasonably high, I would say. The BCG scar presence was 70%, and tuberculosis preventive therapy during that time because it was only for the under 5 and HIV, the coverage was 16%. Probably it was also affected because of the COVID. Underweight in contacts. So if we look at adults, it is a little higher than what we have seen in NFHS. So that is what, when we look at the means, it hides pockets where the undernutrition is very high. So in adults, it was 35% and 39% in control and intervention respectively. Almost 50% of the children were underweight, and adolescents, it was 21% in control and higher in intervention arm. So I ask Anurag to continue from here about the outcomes. No, you can do it from here. Okay, okay. So I'll control the slides. Okay. You can change the slides from here.
So Madhvi has described some of the processes in our trial and the setting, of course, of a predominantly rural, predominantly HIV negative population with issues of poverty. And this is a slide which summarizes all the outcomes in the contacts at the end of 2 years of follow-up. And we can see the incident cases of total of 218, more in the control arm, coprevalent cases. Loss to follow-up was relatively, acceptable at less than 5% in the intervention arm, just about that in the control arm. There were relatively few withdrawals, and there were a total of 127 deaths, which were actually almost equal in the two arms, because we had a larger population of patients in the of contacts in the intervention arm. So now, many of you must have already seen the paper, so this is not new to you. But the TB incidence in the household contacts, which is the primary outcome, this table summarizes what we found. And 122 cases of all forms of incident TB were seen in the control arm against 96 in the intervention arm. We had person time of follow-up also. So relatively, totally we had about more than 21,000 person years of follow-up. And the incidence rates of about 1.3 and 0.78. The incidence rate ratio of TB incidence of intervention versus control was 0.61. And this was adjusted for the confounding factors of tobacco use, alcohol use, age, BCG scar, TPT, etc. So the incidence rate ratio is 0.61. This translates into a 39% reduction of TB incidence in the intervention arm compared to the control arm. And using other multivariable analysis, we found out adjusted heart ratio. It was about 0.59. So overall, it was close to 40% reduction of TB incidence of all forms of TB in the intervention arm compared to the control arm. Now, one may argue that this may have got diluted by misdiagnosis of cases, etc. But when we restricted the analysis to those who are microbiologically confirmed, there were about 153 cases which were microbiologically confirmed. And again, these were more significantly more in the control arm. And here the incidence rate ratio was 0.52, the adjusted, meaning that there was a 48% reduction in TB incidence in the intervention arm. And again, the hazard ratio was similar. So we had...
I'm not moving the slides, so I will have to move the slides. You have to use the mouse.
Okay.
This, sir.
That's nice. So I'll just maybe give you a all forms of TB in the intervention arm to about 50% if we restrict to those with lung TB, which is the infectious form of TB. This is a Kaplan-Meier analysis, which shows that actually the two arms started diverging in terms of TB incidence after about 6 months. And they continue to diverge even at the end of follow-up, which in some cases was even more than 2 years to compensate for the decreased follow-up in some of the households because of delayed enrollment. So in the characteristics of the incident TB in the household contacts, most were in adults, relatively few in children below 5, and in the then in the 16-17 age group. It was also difficult to establish diagnosis in the under 5s for a variety of reasons, including getting gastric aspirations done. In the contacts who developed incident TB were older than those who did not develop incident TB. They had a lower weight of about by 4 kgs, lower BMI, and a little higher use of tobacco and alcohol. These patients, on the average weight, the weight gain was only about 2.5% against 4% weight gain in those contacts who did not develop incident TB. If we take the median weight gains in the household contacts, again, the weight gains may look modest here, but this was also complicated by the fact that some of the contacts actually lost weight during follow-up, and this weight loss was more in those who were normal in weight. So, but there was a significant difference in the weight gains in the intervention versus the control arm. And overall, there was better weight gain in intervention arm, both in adult men and women and boys and girls. In the under 5s, there was no significant difference. The prevalence of low BMI declined by 11 percentage points in the intervention arm, and it did also decline in the control arm, but to a lesser extent. This was around a 28% relative reduction in prevalence of low BMI with a 6-month intervention. When we come to the patient's outcomes, we found that overall treatment success was 94%, which was significantly higher than what is seen in the national program. Of course, this was a trial condition. Most patients, many patients could not have smear documented at the end of therapy, but they had clinical response and weight gain. The average weight gain was 4.6 kgs, but there was a big range from about 2.3 to even 23 kgs. Unfavorable outcomes were there in about 5%. And during the 6 months of TB treatment, any death which occurs is called as a TB death. This was about 3.9%. There was low rate of loss to follow-up and treatment failure in our cohort. Now, if you take, again, as Madhuri has this provided an opportunity to do more comprehensive evaluation of patients at baseline to look for what are the factors that can predict TB death. And we found two simple, robust things. One is the functional status. If somebody, now in this Kaplan-Meier, we have dichotomized. Instead of 5 categories, we have just made it 3 and 4 and 0, 1, 2. So if you have a poor performance status, that is 3 and 4 ECOG, the mortality was significantly higher, almost 18%, versus significantly lower mortality in those who are mobile. And this is one thing which can be picked up by any health worker in the field level. Body weight also predicted death, and in our cohort, even though diabetes was not very high in prevalence, it was a risk factor for mortality. So you had 5 times more mortality, poor functional status, 3 and per kg increase, the decrease in death was about 5%. Important data for the national program: most deaths, if you want to reduce TB mortality, we have to concentrate on the first 2 months, because most deaths occurred within the first 2 months, and most deaths still occurred at home. 77% occurred. This was not a randomized controlled trial for but what we found is, if the patients gained 5% of their baseline weight in the first 2 months, this reduced the hazard of death by 60%. So this is a finding which is in favor of nutrition support. Even patients with BMIs as low as 8.6 and 10.7 in women and men survived. And these are almost clearly BMIs which can be fatal without nutrition support. Although everybody may assume that patients will gain weight with therapy, recent study, multi-stage study showed that a significant proportion of patients do not gain weight automatically. In fact, they have static BMIs and even lose weight in the first 2 months. And this static or decreasing BMI was associated with a 5-fold higher risk of mortality. So again, clearly, along with effective treatment, if there is supervision with nutrition support, this can make a real difference. Sorry. So the overall mortality was 3.9. We only can compare it with other programmatic cohorts. This was 5.9% in a study published in 2018. And in an older study, in those who weighed less than 35 kgs, the mortality was 14% as against around 7% in our cohort. We did measure the functional status at the end of therapy, and it was very gratifying to see that as opposed to 3% at baseline who could do their normal work, this proportion became 3/4 at the end of treatment. So I'll just summarize now the key learnings from RATIONS trial for TB prevention. As you can see, the nutritional interventions clearly indicated in this community, because 1 in every 3 contacts was underweight and at higher risk of developing TB. Nutrition supplementation to families and communities with serious levels of undernutrition reduced TB incidence by nearly 40 to 50%. This is not a direct comparison with a recent vaccine, but the efficacy of the newly developed M72 vaccine was about 49.6% for reducing TB incidence of lung TB. Nutritional supplementation can powerfully complement other strategies for TB prevention like TPT, and actually can be an incentive and enabler. And also this supplementation did reduce prevalence by a significant percentage, even in few months. So if you consider something which has a protective efficacy for developmental disease as a vaccine, then adequate balanced food, or ABF, can be seen as a vaccine against acid fast bacilli, which is orally active, available over the counter, polyvalent. We know early life nutrition can even increase the risk of non-communicable diseases. It can promote growth and recognition, productivity. It's safe in children and women with no patent issues and guaranteed compliance. What are the learnings for TB care in India as we seek to reduce TB mortality, which is unacceptably high in India? Again, nutrition support in this in our kind of patients who have high prevalence of undernutrition and severe undernutrition should be an integral part of care to ensure better outcomes. And this nutrition support was found to be feasible, acceptable, and led to better treatment completion, weight gain, and return to work, reduced case fatality ratio. Clearly, early weight gain was important in protecting against TB deaths. Apart from anthropometry, these ancillary measures of measuring functional status, oxygen saturation, hemoglobin was feasible, and appropriate triage and referral can save lives. If you look at the number needed to treat for the intervention of nutrition support, it was to prevent 1 case of TB, we would have to support 111 contacts, that is about 30 households. To prevent 1 promising figure, and those with severe undernutrition with weights less than 35 kgs, it's as low as 14. So I would just offer as a comparison that to prevent 1 death in COVID for dexamethasone, the figure was about 36. So this is somewhere in the same range. Next. Cost of implementation, if we just calculate for Jharkhand as an example, with a total notified number as 52,000. If we just support the patients with food baskets for 6 months, the total cost is coming to around 1.5 crores per district, which is actually fairly reasonable. And even if you supplement 3 adults and 1 contact, it will be about 36 crores per district. Again, about 1.5 crores. So for about 3 crores per district, you can actually support both the patient and the family. Next. So in the NTB era, RATIONS has some important, again, take-home messages. An adequate balanced diet with about support of 300 grams per day with, micronutrient pill was a good adjunct to treatment for patients with TB and undernutrition. Comprehensive clinical evaluation can reduce TB deaths. An adequate balanced diet is an adjunct for prevention of people at risk of TB. And this could be a complement to other strategies like vaccination, TPT. And something that the WHO said in 1974 still rings true today, that this may be again an effective protection against most. And what we have done in the rations is simply a reminder to commitment. So when all the member countries committed to the achievement of Sustainable Development Goals in 2015, and one of the commitment was to end poverty and malnutrition by 2030. Many of these SDGs are just to share some stories behind the statistics. This is a tribal boy. His father died a few years ago, and he was about only 24 kgs with a BMI of 10.7. Able to walk after a few weeks of therapy only with a stick, and then became, gained about 16 kgs weight, and now rides a cycle. Next. Again, another family supported, through the trial with food for the family also, and he returned to work in a few months. And he was insisting that he will demonstrate that he can do his normal work. Next. Again, a young lady postpartum developed tuberculosis, again improved with care and nutrition support. And the same patient whom you saw a few slides ago, he survived and became absolutely, normal again with good therapy and nutrition. Next. So these are some of the images from the trial, and this is a photograph from the dissemination meeting that we held in Jharkhand in August last year with colleagues from the State TB cell, Dr. Rakesh Dayal, Dr. Rajiv Ranjan Pathak. Next. This is just an infographic that on the trial, on the main outcomes in the contacts and the patients. So it's my pleasure to acknowledge the support of the ITRC ICMR, including the Director General, Dr. Rajiv Baid, who has taken an active interest in this trial and its findings. Also, the cooperation of ICMR NRT, Dr. Padma and Dr. Banu Rekha and colleagues. Some of our field staff are on this trial. Dr. Ajay Meher continued to be with us till the very end. I acknowledge his contribution, as of Ganesh and Sai Teja. All our field investigators who face very challenging conditions, the State TB cell and the DTOs. And of course, at our end, the departments, the university station, Central Coalfields, who provided lab space, Ekjut for providing local oversight, and the Letstream Foundation. So I'll just stop here and Madhu. Yeah. So now I think we can take questions. Yeah. I'm sorry for some of the technical glitches during the presentation, which some of which were not foreseen.
Thank you, Anurag sir and Madhvi ma'am, for this excellent presentation. Now we will open the Q&A session. I request Dr. Anand sir to begin with the question and answer moderation.
Sure, thank you. I'll do that. Pavitra, if it would be possible, can you kindly share the slide from the Lancet today?
Yes.
Just to highlight the participants in the meantime while we are doing the questions. Madhvi and Anurag, thank you for sharing the findings. Very interesting, certainly, and very relevant from both clinical perspective, public health perspective, and specifically for TB care. There are several questions which have come through in the chat box, and we encourage participants to continue sending any specific questions which might not be unanswered, which are unanswered in the chat box. One of the queries, Madhvi and Anurag, is around the fact that were there any differences in the sort of COVID period and post-COVID period? And maybe linked to that, something I'd like to hear from you as well is, given the challenges of conducting this kind of research, which is community-based across multiple sites, how changes in the findings during the COVID period and after the COVID infection sort of abated a little bit?
So thanks, Anand, for that question from the audience. And yes, we were very cognizant of the fact that what would happen to the patients as well as the contacts during the COVID pandemic. Of course, it was a predominantly rural population. And again, the COVID pandemic had its own time. Jharkhand, but documented effect on mortality was actually not very significant in our population. So we had only about 3 deaths overall during the entire follow-up period in which COVID was actually documented. Now, that was the situation for patients. But we did not see an unusual spike in mortality throughout the COVID pandemic in our patients, which was sort of being anticipated. Regarding the logistics of running the trial during the COVID, again, I think it was a very, very challenging situation because of the disruptions of transport, including the food baskets. But I think where there is a will, there is a way, and the field team showed that once they became a little confident of moving into the community, they found mechanisms by which they could reach the people. And sometimes it was arranging for the family member to come to a barricade and take the ration. But I think there was no disruption in that sense, despite the pandemic. Although, again, it required a lot of effort from the field team and some of us to make sure that kept going.
Please continue with the questions.
Yeah, we'll continue. Yeah.
Okay, so in terms of managing such a trial, both of you were based in Mangalore. The study was happening in Jharkhand. You had a large field team on the ground. You were working closely with colleagues in NHM Jharkhand. But how easy or how difficult was it to manage such a study, sort of being away? If you could speak to that, and that I think would be of use also to a lot of budding researchers who have joined today.
One, we had an excellent local team on the ground. So our project consultant, especially Ajay Meher, was there from the word go till the end when we wound up everything, and Ganesh, and all our field staff. So the ground team was very motivated, but that required very free.
Madhvi and Anurag, I also want to highlight to all participants this infographic, which was just published in the Lancet today. So Lancet today released its 200th bicentennial anniversary issue. And as you would see at the bottom in their infographic of some of the key updates over the 200 years, they've highlighted the ration study as one of the highlights of their 200 years. So certainly, huge credit to the rations team. Congratulations on being featured as part of the Lancet 200-year journey, but also speaking to how much, international attention and policy attention this study is drawing. As you rightly said, this is a study which perhaps should have happened much earlier, but I'm glad that this evidence is out there, and kudos to the team for all the hard work. Now, one of the questions I want to go back to is a question from Khageshwar, who I think is a TB survivor colleague. And Khageshwar is asking that if the liver gets damaged during TB treatment, can the patient continue to take nutritional diet so that the TB drugs, which can sometimes have hepatotoxicity, their effects are minimized? So it's more of a clinical question, but I think a relevant one for patients and in terms of lived experience. So Anurag or Madhvi, if you could take that.
Yeah, Khageshwar, in fact, was part of the trial team. He joined a little later in the trial, but yeah, he's So what this was a point of concern that undernourished patients have a higher risk of drug-induced hepatotoxicity. But we found relatively few patients in the trial, a total of about only 8 out of the 2,800, who developed clinically, evident hepatotoxicity. There are numerous misconceptions about, diet and liver disease, which make people feel that they should, give up everything and be on a kind of highly restricted diet, which is not true. So my answer would be that a good diet and abstinence from alcohol can actually protect against liver toxicity. And by the time, if you have liver toxicity, if you just manage the nausea and the anorexia and continue the food, this is not going to be of any, adverse effect in terms of the food itself.
And we did not see refeeding syndrome, at least in our patients.
Refeeding syndrome, a lot of, the ethics committee as well as the DSMB was feeling that would there be a refeeding syndrome in these severely underweight group of patients? We did talk about this in the training, that the feeding should be cautious and not very aggressive in the first week. But we did not see any, complications of that nature. Also because they're they have a lot of loss of appetite, so they don't really take, food aggressively in the first week. Yeah.
So there is a next question which reads, was provision of direct benefit transfer of rupees 500 per month adjusted among the intervention and control groups? It would be great to analyze and understand how were these differences distributed among the two groups.
Yeah, that's a question which keeps on coming up. But the thing is that the current Nikshay system doesn't give you accurate information, updated information on how many installments the patient has received. Even the indicator in the TV reports is how many have received the first installment. So there is an issue about, the scheme itself is good, but there's an issue of timeliness. And so we could not retrieve this data, whether everybody got really DBT throughout the course of treatment. I would think that in such a large population, whatever factors like these are would be equally distributed. So we had a mix of all kinds of patients, rural, urban, and I don't think that may have confounded the analysis. But we have not adjusted for that. We adjusted for the economic status of the patient as revealed in the asset score. So we took account of 23 household assets and calculated how much they would cost. So we took that into account into the analysis. Yeah.
So I'll just add that not just DBT, but ICDS, midday meals, the PDS. So in a trial, that's the beauty of the trial, that because it is a cluster randomized trial, these are distributed, equally between the arms. So these co-interventions continued.
Okay.
We could not have, controlled them or, really,
Okay, shall I move to the next question, ma'am? So the question is, was there any difference in outcomes across the 4 districts that were part of the trial?
It's part of the supplementary material if you want to see the details.
Yeah, so this district-wide analysis is available in the supplementary material in the thing. But so West Singhbhum is the district where the tribal proportion of tribal patients was the highest. The levels of nutrition were the lowest. And in that sense, that did have the highest case fatality ratio amongst the patients. But in terms of contacts, I think there was a reasonable, I would say, not marked difference between the incidence of contacts across the 4 districts. But in terms of patients' outcomes, yes, West Singhbhum with its problem of access, high tribal population with higher levels of undernutrition, it was this thing. And therefore, Jamshedpur with a higher urban population, more industrialized, that was lower. Yeah. So we did see district-wide different. But all these analyses have been done with taking into account clustering.
Yes.
Everything has been taking into account clustering. And the clustering was at the TU level, not the district level. So I'm just clarifying that all these analyses are adjusted for
So when
clustering.
you look at, when you account for clustering, all the co-interventions, I just saw a question also pop up. So some of these co-interventions, when we account for clustering, get adjusted automatically.
So the supplementary material will be
Yes.
a huge thing. So the next question, ma'am, are there any specific gendered or gender-specific findings of the study?
So we do have gender-specific findings, especially in children and adolescents. So some of these things are available again in the supplementary material as far as contacts are concerned. In case of patients, gender-specific difference in results.
In patients per se, as you all know, the prevalence of TB is more in males in India than in females. And it was so also 70% of our patients were actually men rather than women. Women, however, had a poorer nutrition status, but in spite of that, the mortality was again a little lower in women despite their thing. So there are some biological differences there. What we found was that the baseline was lower, but the weight gain, fortunately in our trial, was from the baseline, the percentage weight gain was similar in both groups.
Yes.
And also what we found was that the lower the weight at baseline, the higher was the weight gain. So that was also, in the most underweight group, the average weight gain was 6.7 kgs. But if you move to somebody with normal or, a little overweight, it was hardly 2 kgs. And in that sense, again, I may just add here, although it's not a question, we did not find an increase in overweight obesity either in the patients or contacts with this nutritional intervention.
Which is a very common question.
So the prevalence of overweight obesity was low, was very low in patients, was low in contacts, about 6%. So there was no very marked change with the intervention. Of course, the real issue in our trial was that the COVID disrupted livelihoods, disrupted the family economy. So there were so many factors at play here, which could have had an impact, on our results.
So the baseline intakes would have got affected because of COVID, which we would not have been able to control at all.
Great, thanks, Madhvi and Anurag. So, I know both of you worked in JSS and been interacting with patients who certainly come from the margins, including of the health system. But I want you to maybe reinforce for our participants what's the kind of weight, baseline weights that you are seeing, because I think one of your slides spoke to the minimum weight that you saw. And that should be a reminder to our policymakers, to our researchers, that what do our guidelines say versus where is the social reality. So if you could just highlight that data again and reinforce why it's important to look at TB, not just from a sort of a clinical drug treatment perspective, but this social perspective.
Yeah, so thanks for that question, Anant. So I trained in internal medicine at the All India Institute of Medical Sciences, which at that time was not admitting TB patients. So when I moved to rural India in 1994 and then to Chhattisgarh, the scale of the undernutrition, both in normal people and in patients, was surprising and shocking. And before our study got published in 2013, we did not have an accurate estimation of nutritional status in India in adults, because that requires height measurement and calculation of BMI. So when we started measuring the BMI, we found that, as in the study, it was almost identical. The only marginal difference is that the median BMI in our Chhattisgarh study was 15 in women and 16 in men, which means half of women had a BMI less than 15. I might remind people that if the BMI goes below 11 in women and 13 in men, it's supposed to be fatal for this thing. And we were seeing these kind of patients. And at that time, nutritional assessment or nutritional support was not part of the TB discourse, which was focused on only treatment with antibacterial drugs. So somehow this issue of the overall view of the patient, and I think this is now high time that we see the problem in a holistic sense, the patient in a social context, and an overall view of the patient itself, including undernutrition. We cannot be learning these lessons, gradually one by one, that it is important to assess and address undernutrition. It is important to assess and address, diabetes or other comorbidities. So if we take a comprehensive view, I think we will get much better results for our treatment than focusing only on the sputum. Because from the point of view of the patient, if the patient is not able to work after treatment because of severe disease or dies during treatment, it is not a cure at all. So fortunately, the WHO published a guideline in 2013, which said that all patients should be having a nutritional assessment done, counseling done, and support if they have severe undernutrition. But this is still not a reality for most countries. At least we have moved forward in this space in India. But again, we are not in a situation where we can say that right now. I cannot say that a patient with a BMI of 13 in Jharkhand who gets diagnosed today will necessarily get that a diagnosis of severe undernutrition and get access to a food basket and supervision. So I think it's something of concern to all of us. I think we draw a wrong dichotomy between clinical medicine and public health. I think as clinicians, we need to look at more of public health aspects, including social determinants, and the public health people also should look at the clinical aspects. So I think when we merge these perspectives, we get a holistic view of the disease, both for the sake of patients and the communities, and we'll move forward. I must say this, that the rates that we have recorded in Chhattisgarh and Jharkhand are the lowest globally in a population which is predominantly HIV negative. So I think the problem is urgent for patients and of serious nature for contacts. And I think this should just motivate us to work collectively towards addressing these issues.
So I must just add that apart from weights, we also looked at heights. And heights become very important in our population where we are not able to, actually the BMI may look normal in a person who is extremely stunted. So even that needs to be, and now it is being recorded in the program, in the card. So I also see a last question, which is easy to address at the moment. So Anant, I will just answer that question, that how these results have impacted the policy decision. So we are very happy to share that ICMR was, we first made a private presentation with ICMR and Niti Aayog. Then we had a nationwide dissemination for all the stakeholders through ICMR, and there was a very rich discussion. So it is being taken very seriously. It has figured in Lancet Commission, which goes to UNHLM for discussion. And I must say that Nikshay Mitra, although it's not the best way forward, but has taken a lot of ideas from the preliminary results of the RATIONS trial. So it is being noticed, and it is being taken forward in a remarkable way. And of course, lots need to be done. Any other question?
One question from Dr. Veena was around the fact that do you have a caste breakdown of your participants, and how is that a factor in your analysis as well?
It's tribal.
So the overwhelming numbers were tribal in origin. So 2/3 were, tribals, and so proportionately for all outcomes, including deaths, actually most of them occurred in tribal communities. Again, there are about almost 32, different scheduled tribes in Jharkhand alone, and some of them are, particularly vulnerable tribal groups. So I think it's a point of major concern. And when you have a ministry specifically dedicated to tribal affairs, I think that needs to take into account this situation for TB patients. Again, tribal patients are supposed to, get additional incentives like, 750 rupees on completion of therapy, some, facilitation for transport, etc. But again, sometimes this is a challenge in terms of when we assess, whether they've got it. Another issue which is unrelated, which I want to point out here, because we are all concerned about it, is that what happens to a family when a patient dies of TB? And for a number of years, I even pointed this out in the national policy document on nutritional care and support. There is a national social assistance scheme which provides 20,000 in case somebody dies of TB or HIV. But again, on the ground, this support is not accessible. So I'm just saying that while we look at diagnostics and newer therapies, apart from the DBT, we also have to see at what happens to a family and if the person dies. Tribal patients again have, as you said, are on the margins, and they find it the most difficulty in accessing care. One result from this trial is that if access to inpatient care can be facilitated and assured, we will see an immediate decline in mortality. Probably that is what is happening in Tamil Nadu in the TNCAT scheme. So with proper risk assessment and referral, mortality is coming down. So
So there is one question by Prabir and Swati Krishna. So I'll answer that, and their both questions are related. So Prabir asks whether we should have e-vouchers if people are staying in very distant hamlets, and Swati says that can we depend on PDS for upscaling. So this was again discussed in detail with ICMR and Central TB Division, and it seems that we should not be advocating only for one type of intervention. It is not this or that, and it should always be this as well as that. So it has to be decentralized depending on the state, depending on the resources. And if there are really difficult to reach areas, probably e-vouchers might work with facilitation on where to buy those things. So yes, PDS is one of the mainstay where we would say if we have to upscale, then addition of pulses in PDS is one of the best ways to go about it. But as Prabir mentions, for very difficult to reach areas, probably we'll have to think of other mechanisms.
There is a question.
Pavitra, I just want to add on a question which I think is very interesting, because it's an issue which comes up in Anganwadis as well, right? With the RTF debate, that in our TB response, based on your study findings, should we be looking at adapting our food interventions to the local food culture, to the local food basket, so local biodiversity, indigenous knowledge, so that it's not a one-size-fits-all kind of a response, and it goes back to your points around marginalization, etc. So any thoughts on what could be done in that space?
Yeah, you are right, Anand. So the guidance document has a lot of possibilities already there in the basket, keeping in mind the diversity in India, but definitely the basket has to be evolved locally, keeping in mind the cultural context, because we cannot change the dietary styles, which can be very harmful in long run. So it has to be, and I must mention here that we did start with groundnut to begin with in our food basket, which was preferred, but because there was a problem in storage and the first batch had problem with fungus, so we had to shift from that to sattu, and fortunately okay, so fortunately sattu was something which was preferred locally. There are many ways in which it can be consumed. So we added that component in our counseling material, where we also explained the participants, various possibilities. And in that, the Lady Hardinge College, the National Center for Excellence in Dietetics, helped us evolve many things. Post-trial.
The post-trial effects is one of the questions, ma'am, which is on the similar line. Like, how will the interruption of nutritional baskets are impacting the intervention group now, and any steps taken to minimize the change?
That is very point of concern for any investigator. What happens to the community after you have stopped the trial? So we have been really trying to take up the matter with the Jharkhand administration in this regard, to at least see that the communities in Jharkhand, which I think are in a very different state of precarity, do not suffer such severe levels of undernutrition. So we will keep up the kind of conversation and keep up maybe the pressure. So we are trying to ensure best to ensure this in Jharkhand and neighboring states like Chhattisgarh, who have shown some response to this. But yes, I think at a national level, because it is being taken up by the Nikshay Mitra, even if we say that, okay, Nikshay Mitra will be comprehensive and not be only donor initiated, but kind of supervised by the program, that will be a step forward. And Jharkhand in particular has enough corporate organizations, public sector, which can actually take up the Nikshay Mitra, provided it's reframed in that context. Regarding, I think Anant had said that. Sorry. Yeah. So BMI below BMI, BMI has its own limitations. Anant, thanks for your question.
You'll have to take the question because others might not.
Okay. Anant wanted to know, and one other member, whether there's a cutoff for BMI below you would support a patient. Now, the way to look at it is that the WHO guideline says that only below 16 should you initiate nutritional support. But this doesn't take into account that even people with BMI of moderate nature are at risk of death and of developing drug toxicity. So for the moderate, they are saying that you wait and watch for the first 2 months. And if they don't gain weight, then you support them. But that, as I've told you, the first 2 months are critical, and you may lose the patient before you, initiate nutritional support. So, given the light of what we are seeing here, it makes more sense to initiate food, support and all. But yes, I feel that one of the results in this trial we could not focus was different patients may require different grades of nutrition support and for different duration. So this food basket that we used for all patients was not sufficient to bring everybody across the threshold of normal BMI as 18.5. So some patients required extension of food support even beyond 6 months. So I think what we need is data at a local level for each state, and this can be easily done, that what is the anthropometric profile of our patients, and then we can design the intervention accordingly. But discriminating against patients, based on their BMI, most of them will have low BMI or normal BMI, which is at risk of becoming low. So the support should be across. And again, one thing which we did not show here was that even in patients who had a normal BMI, this intervention provided protective efficacy. Actually, it was higher in those with normal weights. So we are assuming that everybody below 18.5 is underweight and everybody above 18.5 is normal in immune function, but that is not true of TB. And up to a BMI of almost 23, you still have higher risk. So again, discriminating with the one kind of cutoff would not be proper.
So I know we are almost at time, but Anurag and Madhvi put both of you on a spot. Based on rations, the gap is always sometimes for researchers the evidence to policy to implementation gap. So what would be your one sort of takeaway or in terms of what needs to be done from a policy perspective and especially from an implementation perspective?
So the takeaways already have been, so one set of takeaway for the patients is that whether it is rations data or Chhattisgarh data of 2013 or NTP data of 2018 or a recent cohort of NTP by Report India, we have patients who are undernourished, who are not gaining weight when there is no food support. So food support in patients with tuberculosis is, yes, required. For food support in communities where there is high prevalence of undernutrition in the community, in that case, we really need to think about ways and means to do it for the household contacts. And that basket has to be evolved locally. The mechanisms have to be evolved by the states in a decentralized manner. It cannot come from top. The mechanisms will have to be devised. And again, they need to be documented. The learnings need to be disseminated so that they can be refined further. And lastly, Nikshay Mitra is a very important development, but we cannot depend on individual donors because our requirements are huge. And moment we depend on individual donors, we cannot control the kind of food basket that is being given. We should not be advocating for processed foods that can get entry into these food baskets. And it should be food-based and not at all in terms of fortified foods and ready-to-use therapeutic foods. I hope I've answered the question, Anant. You want to add
Excellent
something?
points, and maybe if I can just add from Veena Shatrugnan as well in the chat that any targeting for food distribution ends up in failure. Food support must be universal for all TB patients. I think a great takeaway message as well. I'll now hand it over to Pavitra, and we want to finish.
I'll just maybe one last intervention. Sorry for this, but
go ahead.
I just want to say that we are talking of the outcome of improved nutrition. Now, there are various ways of addressing nutrition. It could be one way would be rural livelihoods. The other way would be agricultural systems and reforms. Third thing could be direct intervention. So I just want to clarify for this audience again that we are talking of two interventions here. One is a specific intervention for patients, which is almost like a clinical intervention and which should be rolled out immediately. And the second intervention is, again, to be most effective, you will have to address the nutrition of the population as a whole rather than only of household contacts. Now, we know from our demographic surveys, the NFHS, where the problem is most acute of undernutrition. So that is a public health intervention, and this should come in the center of our development agenda in India. I think this factor that we are trying to say that these things don't work, we have not exploited the whole range of nutritional interventions. We have limited ourselves to fortification with micronutrients, single or multiple. So I think if we make it central to the developmental agenda and look at it as a central thing, as I pointed in my last slide, we will see a very, very significant decline immediately of the burden of TB as well as many other diseases. And our communities need this intervention across age groups. We know the situation, by district. So I think if we work from the bottom up and the collectors handle this, okay, our district has a very high level of undernutrition in this thing, let's evolve this. So it's a multi-sectoral effort. The outcome is, of course, tracking the nutritional status. So that is a public health intervention. We have just pointed out here that a food intervention can bring down TB. Now it's left to the wisdom of all of us and the government to see how best we can address it. But one of my friends was saying that I don't work in TB, I work in rural livelihoods. I said, yes, you are working in TB also, because if you're improving livelihoods, you're decreasing TB incidence. So that was my message. So I am not saying that we should just roll out only food support across the country. But yes, our PDS basket needs to be more diversified, better dietary quality there with the addition of pulses, which we have found has made a difference in our trial. So a diversified and enhanced PDS would be a good mechanism to take this trial results forward.
Thanks a lot. Pavitra, over to you to wrap up.
Thank you, sir. It's a pleasure to propose the vote of thanks today. I thank our university officials for providing their support for this webinar. Heartfelt thanks to our Honorable VC, Dr. M. Vijay Kumar, for taking his time out and providing the opening remarks. Special thanks to Dr. Anant Bhan for moderating this webinar. Heartfelt thanks to Drs. Anurag and Madhavi Bhargava for providing us with the succinct presentation of trial findings and also its implications. I also thank the Departments of General Medicine and Community Medicine for their support, and also big thanks to Center for Ethics for providing us with the Zoom platform for today's webinar. My thanks to our IT team for providing their support in hosting this program, and also to the audience for your interesting questions, which made the Q&A session quite enriching. Thank you, one and all.
Thank you all.
Thank you.
Thank you all.
Thank you.